So for our next panel, we have two incredible folks. Dr. Gary Tsai, he is a physician executive. He is also the director of the Substance Use Prevention and Control Division of LA's County Department of Public Health. In his role, he's responsible for leading nearly 500 staff with a budget of approximately $460 million, and he oversees a full spectrum of substance use prevention, harm reduction, and treatment services for 10 million residents of LA County. And we also have Brandon Fernandez. He's the CEO of Cry Help, a nonprofit corporation specializing in the treatment of substance use and co-occurring disorders. Cry Help was founded in 1971, serves over 3,000 patients annually in its withdrawal management, residential and outpatient levels of care, and employs over 220 full-time employees. Cry Help spans 10 locations across LA County, including 288 residential treatment beds. Sorry, it said DHCS, threw me off. And over 100 recovery residence beds. Cry Help's headquarters, the George and Tom Pfleger Center, is one of the largest DHCS licensed residential treatment centers in California. And so before I officially welcome them up, what they are going to be talking about today is something I'm very excited about. It's the Drug Medi-Cal Organized Delivery System. And on August 13th, just last week, she celebrated her 10th birthday. And I am just shocked. Yes, that's amazing for those of you that have been in this field for 10 years, just a remarkable effort. And so both of the gentlemen are going to come up and give us kind of an update of what's been happening these last 10 years. So please join me in welcoming them on the stage.
All right. Good morning, everyone. Hello, hello. Is this working? Yeah. All right. So first off, Brandon and I were talking. We want to sincerely thank DHCS for putting us after a Tonight Show comedian. That was fantastic. I was considering whether or not I should actually put my jacket on because I'm sweating so much from laughing. But yeah, thank you for having us. I think when we had come up with this topic, I recognized that 2025, this is the 10-year anniversary of the Drug Medi-Cal Organized Delivery System waiver, DMCODS, right? First in the country waiver for us to actually fund substance use services through the largest payer in the country, a comprehensive continuum of services with financial backing around the services that are actually needed for the clients that we care for. And so today we're going to be focusing on a couple of things. Just by the title, you can get a sense of what they are, right? Moving from a grant-based diet to DMCODS, a journey beyond bins, right? So the first part of this title is really around the change, right? The changes under DMCODS. Obviously, the title refers to financing. There are also other changes that we'll cover. And the second part really refers to change management, right? A journey beyond bins. I think many of us here know behavioral health information notices, beloved documents that help to guide the services that we provide. And so the change management process involved the bins, but also a lot more in addition to that, right? And so what we'll cover today, and this is actually a two-part series. The first part is right now. This is the plenary. The second part is a little bit later this afternoon, where we're going to go into a little bit more detail than what we'll cover this morning. So, if you're interested, if we're good enough in this first session, consider coming in the afternoon where Brandon and I and Scott from Placer County will dive into a bit more detail. But with that, did you want to say any words before we get started?
I'll chime in.
Okay. All right.
I want to follow up on a lot.
Great. All right. So I'm going to talk a little bit about the Drug Medi-Cal Organized Delivery System waiver, or DMCODS, as an overview. I assume most people in here probably are familiar with DMCODS, but I would also assume that some people are not. And so this should hopefully catch us up. Then I'll talk about our implementation experience in Los Angeles County. Hopefully that's helpful for everyone, whether you're a counselor, practitioner at the frontline level, an agency serving Medi-Cal clients, or a county designing and implementing this system. Starting out, why this matters, right? So a couple data points, which is always great to follow after 22 minutes of jokes. 2/3 of Americans, this is according to a Kaiser Family Foundation survey, right, say that they've been impacted by substance use in some way, whether it's themselves, their family, friends. 2/3. That's a whole lot of people in this room, right? But this room is probably a little bit unique. 17% of people in the United States have a substance use disorder. This is the prevalence of substance use disorders. It's a very significant number, right? Higher than serious mental illness, right? And then under 15% of those receive treatment in the past year, and only less than 6% receive treatment in the specialty substance use system, right? So we have the specialty system, which is drug Medi-Cal in California. We have the non-specialty substance use system, which could be provided by your primary care clinic within your managed care plan, right? And all of these data points tell us that we have a great opportunity to do better, right? It's not that we're not doing our best or not doing good work or that people can't recover, but there's a lot of margin for improvement in the work that we do. That's actually the reason why I'm interested in this field, right? Some fundamental assumptions too, before I get started. Especially substance use is a system and not a program. This is a very important distinction, right? And just by the very simplistic graphic here, right? When I think about the system, I think of the entirety, right? And then within that system, we have a number of different programs, right? I think of the substance use system, as I just said, as a system, right? And how you think of it is important because it impacts your approach, your attention, your resources, right? And so I think that's one fundamental assumption. The next is DMCODS is a generational opportunity for us to invest in the specialty substance use system in ways that we've never done in this country before, right? 10 years ago, we embarked on this journey. And you'll hear a little bit about our experience, at least in Los Angeles and at CryHelp, which is one of our agencies in Los Angeles. I feel truly lucky to be a part of the change that's happened under DMCODS, and we'll talk a little bit about why. The third point is around DMCODS as an ongoing system transformation, right? DMCODS is not a box to be checked, right? There's a lot of different priorities that we as a state have right now, right? There's BH Connect, there's CalAIM, there's PathJI, Justice Involved. There's a whole host of really important things. But because DMCODS is a system and is a pillar of behavioral health, right? Pillar being there's mental health, substance use. It's just important for us to recognize that there's a lot of improvement that we need to be doing. And it's not simply saying we implemented DMCODS. Great. Let's focus on something else. There's so much that we could be working on, right? Okay, so moving forward, overview. Earlier, I mentioned, first in the nation waiver, right? So what is DMCODS? This is a Section 1115 waiver that was approved by CMS at the federal level in 2015. And then there was an additional Section 1915B waiver that was added with the CalAIM in 2022. That's a Medicaid waiver that funded the specialty substance use services in California so that there was a broader scope of Medi-Cal reimbursable services, in addition to a number of other changes, including moving the substance use system into a managed care environment. California was the first. We were the first state in the nation to pursue this. Since California pursued this, and kudos to the state and DHCS for their leadership and vision in that pursuit, but since California's implemented, there's been, I believe, over 30 other states that have implemented similar waivers. Recently, CMS approved, I think Nebraska had their renewal come up, right? So that's a good sign that their waiver was renewed. But it's really, in my mind, the single greatest opportunity for us to meaningfully design, and implement a substance use system with the financial and clinical resources that we need to serve the people that you all serve, that we all serve, in the way that they deserve and in the way that we want. Incredibly, incredibly important. Some of the changes with this waiver were around needing to now meet federal managed care requirements, following the American Society of Addiction Medicine, or ASAM, criteria, as well as using ASAM assessments, establishing utilization review processes, particularly for residential care, standing up a 24/7 call center, right? And there were also very significant fiscal policy changes. I'm a big believer in needing to pay attention to how we finance health systems to ensure that we're setting those systems up for success. And that's, in my opinion, what DMCODS did, right? So it made Medicaid the first payer for specialty substance use services across the state for counties that opted in. It expanded reimbursement through Medicaid for levels of care that previously were not reimbursed for, allowed coverage for things like medications for addiction treatment, or MAT, things like care coordination or case management, right? Which people working in other systems kind of are blown away when I tell them that before the DMCODS, case management was even reimbursable, right? And this one's important, and it's going to sound very dry, but it's probably one of the most important things, which is built into the DMCODS waiver is an exemption from the Institutes for Mental Disease, or IMD exclusion, right? Which is a federal policy that says Medicaid won't reimburse services provided in a facility with more than 16 beds that meets the criteria as an IMD. The reason why that's important, just one example. In Los Angeles, 95% of our residential beds are in IMDs, meaning if we didn't have this exemption, 95% of our residential beds, we would have to find some other way to fund and couldn't rely on Medicaid. That is very significant, right? On the left table, you can just see some of the old drug Medi-Cal benefits. On the right, the DMCODS waiver benefits. Obviously, the list on the right is longer, right? People are blown away also when I say that prior to DMCODS, if you were a man that needed residential substance use treatment, Medi-Cal or Medicaid said, sorry, we can't pay for that, right? If you're a perinatal woman, then yes, we can pay for it. Obviously, that doesn't make a lot of sense, right? DMCODS gave us the opportunity to close that loophole. The continuum of care, right? You've probably heard the words continuum of care a lot during the conference. These are the various levels of care under DMCODS: outpatient, intensive outpatient, various residential levels of care, various withdrawal management levels of care, opioid treatment programs, also known as narcotic treatment programs, recovery support services, which is essentially a lower level of care, kind of below outpatient, early intervention services, as well as EPSDT for youth as defined federally. And then recovery-oriented housing is not part of the DMCODS waiver, but is something that I know in LA and in many other counties are funded in other ways to supplement the services that are provided through DMCODS. So this gives you a sense of the continuum of services that are funded through Medicaid as a result of the opportunities afforded through DMCODS. Okay, one of my favorite parts. Shifting from a grant-based diet to DMCODS. What does that mean, right? So previously, before DMCODS, many SUD systems, including here in Los Angeles, piecemealed various fragmented funding that we were able to attain into what we at that time called the substance use system, right? And each funding had different criteria. So if you were a general relief client, you could have access to a certain set of services. If you were CalWorks, you would have a different set of services. If you were one of the few drug Medi-Cal providers we had back in the day, then you would have, the kind of very streamlined drug Medi-Cal benefits that were offered back then, right? The big change with DMCODS was making drug Medi-Cal the primary payer of services, and then all of the other funding streams that county systems had access to as secondary funding, meaning that funding could be stretched to pay for things that drug Medi-Cal did not cover, right? Things like room and board, right? Things like recovery-oriented housing, etc. This allowed us essentially to stretch our dollar and to maximize our resources in ways that we were never able to do before. In terms of the outcomes, and this is data straight from the state website. So this is statewide DMCODS data, right? What do we get in terms of the investment in DMCODS? The state has seen over 26% increases in outpatient services, nearly 48% increase in intensive outpatient services, over 400% increase in residential services. Very significant increases. Care coordination now, as I mentioned, is reimbursable. That's been enhanced. That's integration with physical health services has increased and improved. And from a client satisfaction perspective, 93% satisfaction rating, right? That's like 4.5 stars on Amazon, right? That's pretty good. You would put that in your cart. Okay, so hopefully that gets us on the same page in terms of just DMCODS. What am I talking about? We're going to jump into the experience of implementation in Los Angeles County. And just to start off with a couple reasons why I felt this might be helpful, important to cover. You know, one is what Marlise had mentioned. It's 10-year anniversary, right? An opportunity to reflect on progress, on pain, on growth, on learnings. Another important aim of today's plenary is really to provide, hopefully, a practical roadmap for how we, one county, approached DMCODS, and some of the changes that we went through and made in order to maximize this opportunity. Changes related to our organizational structure, changes related to our contracting approach, our fiscal approach, clinical and programmatic functions. And then lastly, to really benefit through this reflection, the change management process that I know is occurring elsewhere in the state, right? Whether you're at the community-based organization level, county level, state level, et cetera. And whether you're a DMC state plan county that hasn't implemented yet, whether you're a DMCODS county that has already implemented, but hopefully is making some adjustments to seek those enhancements, or whether you're a provider agency operating in this space. And so hopefully there's a little bit of something for everyone that's here today. This is what I'm going to get into more detail this afternoon. So, I'm going to quickly go through this, but on the contractual front. So these are some of the changes that we went through when we implemented DMCODS in Los Angeles County, and some of the what I would call kind of sprints, right, in between this marathon that's been the DMCODS journey. Contractually, we've required all of our network. This is actually from year one to be drug Medi-Cal certified. Right, there were a couple of agencies that required a little bit more time. We shifted from a funding-based contracting approach, using all of those different funding streams, all of those different grants that we had before, into what I call more service-based. So drug Medi-Cal, that's one of our contracts. That covers a lot of ground, all the levels of care, right? And then more recently, we right-sized contracts, right? And what I mean by that, that was a way for us to actually lower contract amounts without lowering services, right? How do we do that? We looked at historical spending over the last 3 fiscal years. And in situations where agencies were underspent on that contract, we reallocated the contract. So it was still higher than the highest that they've ever spent over those past 3 fiscal years, but it was lower than what their original amount was, so that we could actually tap into that unused funding that never got tapped into the past 3 fiscal years, right? That was a way to really optimize our financing and ensure that our money was actually going toward services and not just sitting within a budget that never got touched, right? Organizationally, we restructured in a number of ways. Before I even arrived in Los Angeles County, they had brought in a dedicated substance use leadership, such as a medical director. There were new areas that were developed within our organization related to fiscal strategy, managed care, utilization management, et cetera. On the clinical and programmatic front, we implemented EHR the first year of implementation. So we brought what was previously primarily a paper-based system into the electronic age. We also hired a TA vendor to help SAPSI better support our provider network because we contract out all of our services with some of these changes, navigating these changes. And then financially reorganize to really shift our financing from what I would call a transactional approach that we took previously to what is now a much more strategic approach. Those were all very significant changes that occurred over many years as we moved through this journey. Are related to the journey beyond bins, dedicated substance use leadership, in my mind, is essential, right? Whether it's a medical director, whether it's just making sure that individuals, leaders, leading systems and programs are empowered to focus on the needs, priorities of the substance use field and system. Without dedicated staff and without dedicated focus, it's too easy for SUD priorities to become just one of many, right? For it to be diluted among the sea of change that's happening elsewhere. I mentioned, there's so much going on, BH Connect, CalAIM, et cetera. Additionally, we view DMCODS as an opportunity to set standards that we felt were reasonable and appropriate, and they were at times higher than what were set at the federal and state level, right? This is important. It gives us an opportunity to do better and to really construct the system that we think we need to have. And also just an open acknowledgement, there aren't a lot of areas in healthcare where the standards of clinical care are regulated in the way that they're regulated in the substance use field, right? And while I know that there's reasons why that's the case, I think this is also an opportunity for us to kind of move beyond that need so that we're setting appropriate standards. And then lastly, thinking about and approaching the specialty system differently, right? One way to look at this is through supply and demand, right? I think I've heard leaders from across different county departments, right, oftentimes talk about substance use services as almost like an option, right? Yes, great to have. It's very needed, right? But not the entitlement services that it actually is within Medicaid, right? And really thinking about capacity, trying to detach ourselves from this scarcity mindset that is so apparent in the substance use field, whether it's at the agency level or the county level, right? I know that resources are finite, but we have to find a way to kind of get past that, to recognize the finiteness of the resources that we have, but also make very strategic, deliberate decisions about how we invest those resources to result in the system that we and our clients want. And then on the demand side, right, this is the heart of the Reaching the 95% or R95 initiative. An open acknowledgement that the vast majority of people who need our services aren't necessarily interested in it, and they're certainly not receiving it. How do we do better? How do we drive up that demand, right? That's what R95 is about. There's a lot of different approaches that we can take to achieve that. In terms of, I presented earlier on the state DMCODS outcomes at the local level in Los Angeles County. These are some of the positive experiences we've had. We've seen an over 200% increase in residential beds, over 1,000% increase in residential services. This is since we implemented DMCODS. We implemented in 2017, even though the waiver was approved at the federal level in 2015, just because it took a couple years to implement. We've increased Recovery Bridge housing beds by over 700%. Again, this isn't funded through Medicaid, but because of the secondary funding that was freed up, now we were able to invest that in recovery-oriented housing. Our outpatient services have increased by over 50%. We've also significantly increased investments in harm reduction by over 500%, again, because of the secondary funding that was made available. And we've experienced almost 300% increase in prevention investments. We've invested across the board: prevention, harm reduction, treatment, and recovery. That's the full continuum, right? And then around system consolidation and efficiencies, when we look at our residential sites, those have actually gone down a little bit by 26%. However, our residential beds have gone up, right? And so that reflects a consolidation. I think some of that also reflects, as some of us who have been here long enough would remember, back in 2012-ish, there was some CNN-worthy news around fraud across Medi-Cal, right? And as a result of that, there was a dwindling of sites that really probably shouldn't have been delivering services to begin with. I think that was part of the reflection of the reduction in residential sites as well. But on the contracting front, we've also seen 100 less contracts pre-DMCODS to post-DMCODS. Hopefully, for the agencies in the room, they hear administrative streamlining, right? Because with each contract we have, that requires staff at the agency level to help manage that, in addition to the staff that we would need, right? So that represents a simplification. That's a value add for the specialty SUD system. We've seen increases in new admissions by fiscal year. I'm going to start moving faster here. We've seen average lengths of stay. 5 minutes left. I hope that's for just me. Average lengths of stay by level of care go up, right? Particularly when you consider the fact that more people now are receiving multiple episodes of care. That's important, right? We shouldn't just look at the length of stay within one level of care. If someone's actually getting, residential services for 60 days and then outpatient services for a year, right? Those services that they're receiving isn't the 60 days in residential. It's actually, I would add 60 plus a year, right? In terms of MAT, we've seen very significant increases in MAT utilization. We've seen increases in access to naloxone. On the homelessness and housing status front, over the time period of DMCODS, we've seen increases in homeless individuals served. We've also seen more people placed in housing compared to when they first came into our system and when they exited, right? All very positive. And then the treatment effectiveness assessment, which is the T, essentially patient satisfaction focused on a couple different areas that for the sake of time, I'm not going to get into. And then just have a really quick, so I presented on some of the policy, right, from a bureaucrat. This video, very, very brief, less than 2 minutes, is focused on a human story. This is one of the other outcomes of DMCODS.
Yeah, I just don't want my son to know me as the gang-banging dad, or the dad over there on the corner getting high, or the dad who died to an overdose. So at an early age, I committed a lot of crimes. So I've been through jails, been through the institution, and somewhere along the lines of treatment, I realized that that's not what I wanted to do with my life anymore. I got here, everything was cool for about a month, and then I went back to my old neighborhood where I used to live at, and I got high. The temptation was there, the opportunity was there. And when I came back, I admitted to the house manager that was here at that time that I got high, and I felt shame and remorse and embarrassed. Throughout my whole life, I've had abandonment issues where people leave, people don't want me around, right? So after my first relapse and my second relapse, I didn't believe in myself. I didn't have hope. The open arms back to the program was what made me start to believe in myself. And once I started to believe in myself, I had that self-confidence back, but I slowly started changing. I started living life. I've been to a comedy show, which is something I never been to. I've been to the beach for the first time. My perspective on life has changed. I'm very active and in tune in my recovery today. So I'm now a program assistant. I help out at the residential that I went through, so I could tell the clients my story. And tomorrow I'll have a year off of all drugs. Today I know I don't have to live the life that I used to live. And I was noticed, I had a voice here. And that's something that I never had in my life.
Thank you, Gary. Is we're on yet? All right. So my name is Brandon, and I am really excited to share with you about CryHelp's journey today. Candidly, I look across the room, I see colleagues that I've known now for years and years. And what I'd like for you to know is that I think that you'll hear your story today as I tell CryHelp's story. I'm confident that across provider agencies, you could very well be in this exact same seat, and you'd hear over and over again the transformational change that's occurred within our organizations. Before I tell you a little bit more about myself, I'd like to know a little bit more about you. And while Tyler asked everyone to stand yesterday if they're in recovery, I'd like to know who was here working in SUD before DMC ODS was implemented in their county? I'm going to gauge that that's either half or less than half of the room. The reason that that's important to bring up is because at an organization like Cry Help that was founded in 1971, things change over time. And we have generations of the workforce that come in and out of our system. And what happens is that the systems that are in place take on these mythic proportions. And so at Cry Help, we were one of those agencies. We're back in the 70s and 80s. You hear the stories about individuals digging graves with their spoons, walking the track, participating in marathon meetings, wearing signs, and that's not the case today. But we hear these stories. When I joined Cry Help in 2013 as a client receiving services there, I heard these same stories about things that had transitioned. I heard about things like the PSN contract, Prop 36 was just on its way out, but you heard about the different funding streams and what that meant for the treatment that individuals in our care received. What Cry Help looked like before DMC ODS was very different than it looks like today. And I'm confident that across the room, you can acknowledge that within your own treatment organizations, the systems of care look different. One of the things that had just happened that was not necessarily related to DMC ODS that had just occurred, though, was that there was this thing called the Affordable Care Act that went live right around the time that I entered treatment. And if you don't remember this, I'm going to remind you that at one point in time, substance use disorder treatment services were not viewed as an essential health benefit that insurance companies had to cover for treatment. One of the myths that we've heard time and time again at Cry Help is that before Drug Medi-Cal went live, all our residential clients were in treatment from 9 to 12 months. If you didn't work in a system of care before DMC ODS went live, have you heard this story before? The truth is that they weren't. So I'm going to ask you time and time again throughout this presentation to challenge your beliefs. In fact, when we dig into the information, we look into the data, we see that on average, adults that were funded by a public payer system only stayed in treatment for 58 days. This is specifically looking at individuals that were in our level 3.1 or 3.5 levels of care. This excludes individuals that were in our withdrawal management settings, or what was previously called residential detoxification, still is today. And when we look deeper into the data, only 17% of adults were in treatment for 4 months or longer. Even less, only 7% of those individuals were in treatment for 180 days or more. So I ask you to challenge your beliefs. The truth is, the average length of stay at Cry Help today for individuals that are funded through a public payer system is only 4 days less than it was the year before Drug Medi-Cal went live. Again, these stories take on these mythic proportions of how great things were back in the day before Drug Medi-Cal, when individuals could stay in treatment for 9 to 12 months and they could gain stability and they could access work programs. But the truth is that was not the case for the majority of individuals. In fact, I think these stories gained traction because the very slim margin of individuals that did remain in treatment for that long ended up becoming employees, and they stick around with us. And now you have this sort of notion that the people surrounding you are the ones that made it. Another story that we talked about a lot was about what did detox look like before DMC ODS. For us at Cry Help, the average length of stay for adults was 5 days. More importantly, only 13% of adults that were served in our withdrawal management programs were funded by a public payer, and that's because some of the contracts that Gary was discussing, whether it was the CalWorks contract, block grant, they didn't fund withdrawal management in a subacute setting. In fact, for Cry Help, one of the only contracts that we had was through the Ryan White funding that allowed individuals to access withdrawal management services. Otherwise, withdrawal management was funded almost exclusively out of pocket or by individuals who had commercial insurance. I will ask you again to challenge your beliefs, because today the truth is that individuals are in withdrawal management programs longer than they ever were in a pre-DMC ODS setting. In fact, pre-DMC ODS, only 23% of the individuals that were accessing care in our withdrawal management program stayed for a week or longer. Today, that number is 65% of adults that are staying for a week or longer. Only 3% of persons were staying in detox for 10 days or longer. Today, nearly a quarter of the individuals who access services in our withdrawal management program stay for a week or longer. This is a direct result of DMC ODS and the systems that were put in place that allowed for, at least in Los Angeles County, a 14-day initial authorization period for individuals that needed that level of care. And I will tell you, this came right on time as the opioid epidemic started climbing, and drugs like fentanyl presented different clinical considerations that we weren't dealing with in a pre-DMC ODS era. Here's another story. Many of you, I am confident, have seen this happening. We get a phone call. Thanks for calling Cry Help. How can we help you? What do you hear on the other line? It's a mom, it's a dad, it's an individual seeking service, it's a husband, it's a wife. I cannot stop using and I need to access detox. Do you accept Medi-Cal? My heart goes out to our intake staff, and they've heard me say this time and time again. The trauma that was built by having to tell every single individual who called, I'm sorry, we don't accept Medi-Cal for detox or for residential treatment, but if you have time to complete an over-the-phone screening, I can see if one of the counselors is available to assess you. They'd complete the screening, and we spent 15 to 30 minutes conducting an over-the-phone screening where we completed the entire DHCS 5103 healthcare questionnaire and our own internal screening protocol, only to let an individual know that, hey, you are indeed eligible for a county-funded bed, but we're going to place you on a waiting list. And make sure you call every single day so that you can stay on that waiting list, and we'll let you know as soon as a bed is available. I don't know what the story was like at your programs, but at Cry Help, those waiting lists ranged from 4 to 6 months. And individuals simply could not access care in a timely manner. We told ourselves the story that individuals calling on the phone every day meant that they showed that they really wanted it and that they were accountable. The truth is that we don't know how many people passed away or overdosed or didn't access care ultimately because they weren't able to access treatment in a timely manner. Within 2 years of the DMC ODS sort of pilot, well, it went live in July 1, 2017 in Los Angeles County, we noticed that something was changing at Cry Help. And I bring this up because it was important to us as an organization, because we realized we need to make some changes in our staffing, and we need to reevaluate the expertise of the clinicians that are working in our settings. In 2016, Cry Help was a very different place than it is today. In fact, 65% of clients that were admitted to our residential and withdrawal management programs were covered by a commercial insurance, or they were paying out of pocket for treatment. Only 20% of adults reported that they were unhoused at the time of their admissions. Within a 2-year period, only 20% of clients were covered by a commercial insurance policy, and the number of adults that reported they were unhoused at the time of admission had doubled. You all know this firsthand, that the needs of individuals that come from different socioeconomic backgrounds are distinct from one another. The expertise that your staff must have to be able to help persons navigate the conundrum of this resource spiderweb that exists out there is distinct if they're unhoused versus if they have a stable place to go back to post-discharge from treatment. There were a lot of challenges that our organization experienced, and we'll go into these further during the workshop session with Gary this afternoon. The first of which, though, is a refrain that my predecessor commented on during a board meeting before the DMC ODS contracts were executed. We had very recently onboarded an MBA intern, and their task was to contact as many treatment providers as they could in San Mateo County. Shout out to San Mateo County, who I believe was one of the first counties that went live with DMC ODS in the state of California. And their job was to call. And we created a list of questions to ask and say, hey, what's it like? What happened? What did you do to prepare for DMC ODS? Time and time again, the summary that we heard was, staff up now. You have no idea how many phone calls you are going to get. Staff up now. And we provided this report to our board of directors. And our CEO responded, I've been here for 45 years. Substance use disorder funding ebbs and it flows, and we're the political football, and this is going to be just like any other contract. Another one of the issues that we confronted when we gave that same report was we simply cannot afford to hire more staff. And we laid out the new DMC-ODS benefit package, and we did our little calculations, and we reverse engineered what it would look like if we had care coordinators that were actually offering robust case management services and completed a case management treatment plan at the time of admission and worked with them throughout the time of their discharge. And we had counselors that were distinct from the case managers. And the response was the scarcity mindset that Gary's described, that we could not afford to hire more staff. We couldn't afford to hire more intake staff. We couldn't afford to hire those case managers. We could not afford to hire therapists. Another thing that was peculiar about CryHelp, but I mentioned to you that 65% of our admissions were coming through commercial markets or were paying out of pocket, was that we had a distinct phone line for Kaiser Permanente in both our withdrawal management unit and in our residential programs. And that was because our chair of the board at that point in time, who was an executive leader at a managed care organization, said, when Kaiser calls, you respond, you complete the screening, you get them in. And we had this question of, what are we going to do? If there's really all these phone calls and our DMC-ODS beds are going to be full, what happens to the Kaiser phone line? And lastly, we heard this thing time and time again that this is never going to work. They're going to decrease the length of stay for individuals. People aren't going to make it anymore. This simply cannot work. And it was this helpless sort of response of saying, it's happening to us. We can't do this. A few responses on those. The reality was that this was not like any other contract. And I'm sure that all of you can attest and understand that what we've confronted over the last 10 years and what we're doing today is distinct from anything that we were doing prior to the arrival of DMC-ODS. Our systems have been in a constant state of change and flux for the last 8 years or so. At CryHelp, our old thinking left to staffing shortages and underutilized treatment capacity. In fact, we were very slow out the gate when DMC-ODS went live because we still had the same thinking that we could not afford to hire the intake staff because we couldn't get out of the mindset that we operated under previously, where we knew that we had open, underutilized beds, but the bottleneck that occurred at intake disallowed us from conducting enough admissions assessments on the front end to get them into those beds. When it came to the Kaiser phone line, my predecessors on the board made a decision and they said, we are not going to prioritize individuals' abilities to access treatment services based on their funding source. We've got to get rid of the Kaiser phone line. There's one dedicated line that everyone calls into, and we're confident that making those mission-centric decisions was the right call. The truth is that our payer mix today is wildly different than it was 10 years ago. And that is a problem. And I think that most of us here can agree that it's not a best case scenario for any nonprofit community-based organization to be too reliant on one single government county funding source. But we recognize that our mission at that point in time, which was to serve individuals that were underserved, marginalized, uninsured, or underinsured, and to reserve at least 51% of beds for people who could not pay for them, meant that this was the right call for us. And lastly, and this is where I hope I see all of you today, and when I see reports about the BHCP funding and new beds coming online, I think we can all agree that we are thriving in a way today that we were not previously, because before Drug Medi-Cal organized delivery system went live, CryHelp was an organization that missed payroll for its employees. CryHelp was an organization that had to sell properties because we simply could not manage the budgets that we were operating under. The expansion that you've heard about is a direct result of Drug Medi-Cal organized delivery system, and had that issue that I talked about where the Affordable Care Act went live and all of a sudden SUDs were one of the 10 essential health benefits, not coincided with DMC-ODS going live, we would have been in a world of hurt, because I am sure that DHCS can attest that in an era before the ACA, when insurance companies were mandated to cover SUD as a benefit, there simply were not the massive number of 6-bed for-profit treatment centers that exist today. We would have lost out to all of the competition that exists today in terms of what we were doing in the commercial space, and we would have been relying on small government contracts. So 10 years later, what does CryHelp look like? So we offer withdrawal management services across 3 different programs. Today, we have individuals within our sites that are accessing care in a way that they never were previously. In terms of the competencies of the staff, it's something that I'm incredibly proud of. And most important, we accept same-day walk-ins, next-day walk-ins. People can be scheduled to come in. And it's something incredibly special to see and to remember that 10 years ago, we couldn't get you into withdrawal management bed if you were funded by Medi-Cal. The same thing goes for residential, and today we've been able to allocate more of our beds to our LA County and other county contracts for drug Medi-Cal, where we have over 200 residential beds that are contracted for drug Medi-Cal eligible adults. Again, those individuals can very often access services on the same day of their admission or the next day. The problem that we have today is that all too often, all of our residential beds are full. I can remember my predecessor struggling with the issue that at our 135 licensed bed facility, we were at a 50% capacity, but we had already maxed out our contracts. And the question was, like, I wonder what would happen if we just let all these people in without funding available, because that would be the right thing to do. But obviously, like, we just couldn't do it. Gary mentioned that MAT services have expanded under the Drug Medi-Cal Organized Delivery System. Today, MAT services are available on-site, in person, through psychiatrists, psych NPs at all of our residential and outpatient sites, and we offer them through telehealth. That is a direct result of the DMC ODS program. And today, we offer co-occurring enhanced treatment. One of the things that happened between 2016 and 2018, when I mentioned to you that individuals coming into our programs were now presenting from 20% unhoused to 37% unhoused, is that percent is now 70% at CRI-Help's programs. In addition to that, 3/4 of the individuals that admit to our programs report the presence of a co-occurring disorder. What that meant was that we had the opportunity to build more robust treatment teams with multidisciplinary staff to deal with the issues that we were confronting, instead of closing the door and saying, we don't accept individuals who have auditory or visual hallucinations. Schizophrenia, they need to go to a higher level of care. I'm sure that most of you perceive yourselves this way as well. Sometimes CRI-Help is the last house on the block. And we say the story that they need to go to a higher level of care. The truth is, very often there is no higher level of care. We just need them out of our programs because we feel like we can't deal with them. And lastly, Gary mentioned that this is not a DMC ODS benefit. The housing for our adults now, we're at 150 recovery residence beds, and that's directly aligned with the outpatient services that we provide, because we know that housing is healthcare, and we've heard that time and time again today throughout the conference. I think you'll see yourselves in some of these numbers. We increased the number of low-income adults served by over 300% at CRI-Help's residential programs. When I was a client at CRI-Help, oftentimes we'd have 60 individuals in a group in the morning, and then we'd do reading and writing. The whole house is in one room together. At the time, maybe we tried to tell ourselves a story about why that was beneficial, but the truth is, today we're able to operate group sizes. We're at CRI-Help, oftentimes we're running 10 groups at a time, 4 different times a day, and we've reduced the average group size by over 70%, which means that individuals are receiving care that's tailored to them, whether they're in a young person's relapse prevention group, a mature adult's relapse prevention group, or some other type of evidence-based practice. We're incredibly proud of the fact that we've incorporated primary care and mental health services into a specialty SUD treatment setting, where the SUD is the focus as the hub of the individual's condition, and we don't need to send individuals out for care all the time. And we've found out we can do this. And lastly, we've increased our county contract with SAFC by over 721% since DMC ODS went live. What that means for CRI-Help, and what I think it means for many of you, is that the days of missing payroll, the days of paying individuals $10, $11 an hour for work that you know they deserve to get paid more for, have changed. And we've been able to provide things like 401k benefits. We've been able to pay out health insurance at 100% employer-sponsored coverage. We've been able to offer retention bonuses and sign-on bonuses, and we're able to pay the workforce what they afford and what they're worth. The end of the story is that I want to congratulate all of you for going through a wild change management project, and that I hope that you can all recognize how far we've come, and that the stories that we tell ourselves about what it used to be like and what it's like today might not necessarily be true. And know that what we have today that is so fantastic is indeed at risk. These are the types of things that we need to fight for. And so when Gary talks about the benefit that we see of Nebraska's 1115 waiver getting renewed, I'm confident when I hear that, but it doesn't necessarily mean that California's 1115 waiver is going to be renewed. If we were to lose that type of benefit, the SUD system of care crumbles. Acknowledge where we're at, fight for those types of opportunities and rights that we have here. And congratulations for all of you for coming so far in your 10-year anniversary.
All right, great. So I think we have some time for discussion, questions, comments, reactions.
10 minutes. Oh, you got Alonzo up here again.
Yeah.
Yeah.
Where's Alonzo? It was palpable, the energy after Alonzo, and when we came up, it was just very, it was like,
Just grateful I wasn't
All right.
Gary.
yeah.
Good morning.
Hi.
Hi. I just want to thank Cry Help personally because I entered as a resident there in July of 2017. So shout out to the ODS. If not, I wouldn't be sitting here right now getting ready to start grad school.
You can pay me later.
Good morning. Bill from LA Cotta. And I just wanted to underscore what both of you have said. In 2012, I was the manager of our Skid Row facility, and 95% of our patients were not covered by Medi-Cal. We were admitting patients into treatment, I don't know if I should be saying this, that were not funded. We basically had an open door policy. And because of the Affordable Care Act and the Drug Medi-Cal ODS, that all changed in a matter of a year. And now, nearly every participant at our Skid Row facility was able to, be funded for services through Medi-Cal in less than a year. So when you talk about transformational change in a community that was desperate for it, and then I also just wanted to add things such as Recovery Bridge housing and what a game changer that is, and that kind of innovation only comes through, an organized system with the support of great leadership like we have here in LA County. So just wanted to highlight those programs.
Thank you.
Hi there. My name is Dr. Chico. I'm the clinic director at Warner Mountain Indian Health up in Modoc County. That was inspiring to hear this talk today. My thought was, up by us, it's a different life, right? Even after the implementation of this program. I was able to get, I'm doing home detoxes up by me because there's nowhere in the county that's detoxing folks, and folks will get flown out 3.5 hours to Reno for detox and then have to find their way home. And I've worked with clients who had to do the thing where they had to call back to try to get a bed, even in this current system. And then they needed to be detoxed before they went in, and there was no place for them to detox. And so then they lost their bed by the time a bed was open. I was lucky enough to get somebody into a bed right after we finished detoxing them. But we had to call 5 places, in order to find that bed. And so I guess I just wanted to, put that out there as the context that I'm coming from. But the question I had was, I might have missed this, but you had said that in the previous system, folks would be told to call back every day, until a bed became open for them. And you said that wait time was 6 months on average. Was that
We'll call it 4 to 6 months.
4 to 6 months? Okay. And then I think I missed what the wait now is for one of those beds, one of the Medi-Cal beds.
the wait is 0 days now. It by and large the wait is 0 days. I'll clarify that by saying there are instances on a particular day where the beds are full. The reality is that on Mondays in particular, the no-show rate can fluctuate somewhere between 40 to 50%. And so we've also established systems where individuals know that if they can call by 1 p.m., they can get into one of the missed admission slots. You're never waiting more than 48 to 72 hours to get into a bed today. Yeah. And especially as a network in LA County, you can refer out to other providers to ensure that that individual has immediate access to services if they don't intend specifically to come to Cry Help only.
Hi. Hello. Phoebe Bell, Nevada County, and just wanted to say thanks for really shining a light on something, which is the success that we've seen in this area. I think one of the great things about all of us who work in this field is we're deeply conscious of the unbelievable amount of need out there and the suffering that still exists, and that is what drives us to keep doing what we do. But the flip side of that is we sometimes forget to step back and notice the successes that have happened, and it's nothing short of amazing what's happened under, I'd say, the combination of DMC ODS and ACA, and I appreciated that you pointed that out because the threats are on both those fronts right now, and either or both would be devastating to our system. And then the piece I just wanted to call out is one of my fears as a small county is the ways that we end up with bifurcated systems of what bigger and more urban counties can afford and provide and what our small rural counties are able to do. And I feel like it's incumbent on all of us to think about what can we do to build out the rest of the DMC system in our state, given the capacity challenges and provider challenges like MODOC just highlighted that exist in our smaller counties, and what ideas do we have for really building out a statewide system that has been so effective?
Yeah, thank you, Phoebe. Hi, good morning. My name is Justin Phillips. I'm the Executive Director for Auctions Recovery Services up in the San Francisco Bay Area. And I just wanted to comment on some of your statements and just how much you've done in terms of innovation in LA and also just meeting the need. I think with DMC ODS, what it gave us an opportunity to do is really maximize reimbursement rates similarly to how you've outlined. And what we've seen in the San Francisco Bay Area is just a dramatic expansion of SUD services. Our agency included, we tripled in size as a result of the DMC ODS and exclusively focus on intensive outpatient, and recovery residence clinics. And I just want to comment on how great the innovation was in LA County, how much both of you have done, Brandon and your agency, and how you really went out to meet the need. I think we need more of that in our field, and that higher level of care that you're referring to. I mean, we're treating the whole person. I admire what you guys are doing in LA and look forward to see what's to come. So thank you. Thank you.
Okay, great. So I think that is the time that we have this morning. Thank you all for joining us on this 10-year journey. For those who are interested in more details, we'll have a workshop this afternoon. Thank you.